Hello, welcome. Today's discussion is Tetralogy of Fallot. Tetralogy of Fallot is one of the conotruncal family of the heart lesions, in which the primary defect is an anterior deviation of the infundibular septum or the muscular septum that separates the aortic and the pulmonary outflows. Tetralogy of Fallot is the most common cyanotic congenital heart disease in all age groups. It constitutes approximately 8% of congenital heart disease overall. TOF occurs in approximately 0.19 to 0.26 per 1,000 live births. TOF is characterized by the presence of four anatomical findings. Those are ventricular septal defect, pulmonary stenosis, which causes right ventricular outflow obstruction, dextroposition of the aorta or overriding of the aorta, and right ventricular hypertrophy. These are the major defects found in Tetralogy of Fallot that makes it tetra. The initial defect in Tetralogy of Fallot is a narrowing of the right ventricular outflow tract into the pulmonary artery. This prevents deoxygenated blood from entering the pulmonary circuit. In response to this outflow obstruction, the myocardium of the right ventricle hypertrophies in order to contract forcefully enough to push blood past the stenosis. Additionally, patients have a large ventricular septal defect, which allows shunting of blood between the ventricles. Unlike that of VSD, in TOF, the right ventricular outflow obstruction impedes the normal blood flow so significantly that the left side of the heart becomes the path of least resistance. Blood from the right ventricle is then forced into the left ventricle, creating a right-to-left shunt and the subsequent cyanosis. Finally, the aorta overrides the ventricular septal defect, straddling the VSD. This allows deoxygenated blood shunted from the right ventricle to immediately exit the heart, mixed with blood from the left ventricle. The most important determinant of the severity and the clinical consequence of TOF is the degree of right ventricular outflow obstruction, or the degree of pulmonary valve stenosis. With a laser obstruction, blood is shunted from left to right along VSD and permit to preferentially enter the pulmonary circulation, allowing for oxygenation like that of VSD in the case of laser obstruction. With a greater degree of obstruction, blood is forced in the opposite direction away from the pulmonary circulation, leftward across the VSD, and ultimately blood exits the heart before being oxygenated. Approximately 40% of patients with TOF have additional congenital heart defects. Those include pulmonary stenosis, right aortic arc, abnormalities of coronary arteries, collateral vessels supplying pulmonary arteries, PDA, or other defects. Additionally, TOF is associated with a number of genetic syndromes, including Down syndrome as well as DiGeorge syndrome and velocardiofacial syndromes. When we see the presenting signs and the symptoms, the timing and the features of presentation depends on the degree of right ventricular outflow obstruction. Patients with more severe obstruction will present earlier due to cyanosis, mainly during neonatal period or during newborn period. Whereas, for patients with more moderate disease, the presenting signs might be a heart murmur. Finally, for patients with mild disease, with the so-called pink tetralogy, due to the lack of cyanosis, their presentation may consist of signs and symptoms of congestive heart failure due to the left to right shunting across the VSD and the subsequent pulmonary overcirculation. Ultimately, in those with pink tetralogy or mild disease, most patients will become cyanotic as the degree of outflow obstruction increases over time. The other is physical examination. Most importantly, the heart murmur heard in TOF is not due to the ventricular septal defect. In fact, the murmur is due to the right ventricular outflow obstruction or due to the pulmonary valve stenosis. The murmur is typically that of pulmonary stenosis, which is crescendo-decrescendo with harsh systolic ejection quality. It is appreciated best along the left mid to upper sternal border with radiation posteriorly. Patients will have a normal S1 and a possibly single S2 due to diminished P2 component. The other physical finding is cyanosis, and the other is Tate spell. Tate spell are hypercyanotic episodes precipitated by a sudden increase in right to left shunting of blood. They can be elicited by activity such as feeding or crying, or they might occur without warning. The classic description of a patient who becomes cyanotic and then assumes a squatting position to relieve the cyanosis and the hypoxia. Squatting serves to increase peripheral vascular resistance, thereby increasing the pressure in the left heart and subsequently forcing blood back into the pulmonary circulation through the VSD. So squatting serves to shunt blood from left to right, which was initially from left to right to left through the ventricular septal defect. On chest X-ray, patients with TOF have right ventricular hypertrophy, so a boot-shaped heart and decreased pulmonary vascular marking is seen. On echocardiography shows when we see the treatment, once Tetralogy of Fallot is diagnosed, almost all patients undergo corrective surgical repair within the first year of life. In the interim period, prostaglandin treatment might be necessary to maintain the patency of the ductus arteriosus. Additionally, some patients might require digoxin or diuretics if signs of heart failure are present. Treatment of hypercyanotic or Tate spells is directed towards improving pulmonary blood flow. The treatment of Tate spell or hypercyanotic spell include administration of oxygen, knee chest position, morphine, intravenous fluids, small amount, sodium bicarbonate, and beta blockers or pharmacologically increasing systemic vascular resistance by administration of drugs such as phenylephrine. Once an infant has developed progressive cyanosis or has evidence of hypercyanotic spells, surgical correction is indicated. There are two common surgical procedures. The first procedure creates a shunt between the aorta and the pulmonary artery using the subclavian artery. This is called Balalock-Towsing shunt. This is used as a palliative procedure in infants who are not acceptable candidates for intracardiac repair. So, in this case, patients will require additional surgery as this is not a curative surgery. The curative surgery or the definitive repair for patients with TOF is intracardiac repair. This consists of patch closure of septal defect and enlargement of the right ventricular outflow tract with relief of all source of obstruction, and in some cases the pulmonary valve might need to be removed to eliminate the obstruction. Overall, patients undergoing surgical repair for TOF have an excellent prognosis with 20-year survival rate of over 90%. Complications of surgical repair of TOF include arrhythmia, particularly ventricular tachycardia and atrial arrhythmias. Furthermore, patients might experience right ventricular hypertrophy or enlargement due to residual pulmonary stenosis and backward blood flow into the right ventricle. Long-term complications include the need for additional surgeries, neurodevelopmental delay, and myocardial fibrosis. This is all about Tetralogy of Fallot. Thank you for watching.